Hello, everybody. Good afternoon, good morning, or good evening, depending on where you're tuning in from. Of course, we have a global audience. Most of you folks are in the US, as are our panel today. But I imagine we do have some of our European and Asian and even African folks in the room too. So welcome. And I'm really excited to dig into the topic of interoperability today. It's something which can sometimes be seen with almost utopian optimism, something which can solve all of the biggest problems in healthcare. And largely, I think that optimism is shared by many, but I imagine there are some risks involved and threats associated with it too. And so I'm really excited to be able to dig into this meaty topic with four real experts in the space today. So I'm going to ask each of them to introduce themselves, and I'll pick on you as the teacher did, looking around the room as I can see it, and then we'll get stuck into the conversation. So Don, perhaps I could ask you to go first.
Sure. Hello, everyone. My name's Don Woodlock. I'm Vice President of Healthcare for a company called InterSystems, and we help customers, health systems, payers, life sciences with electronic medical records and interoperability generally.
Fantastic. Thanks, Don. And Josh, over to you.
Hi, I'm Josh Lamb. I am a technical lead for interoperability for a health system out of Pennsylvania. So an implementer, implementing the 21st Century Cures rules right now.
Fantastic. Thank you. Amy.
Hi, I'm Amy Trainer. I'm the Vice President of Clinical Systems at Ashner Health in New Orleans and through the state of Louisiana. And I'm super happy to be here today. So thanks for inviting me.
Thank you, Amy. And last but certainly not least, Jeff.
Hi, I'm Jeff Crowd. I'm the Executive Vice President for Northwell Health in New York. It is the largest health system in New York. And you may have recalled, we administered the first dose of the vaccine in America. And I also serve on the board of the New York eHealth Collaborative, which oversees the State Health Information Network. And I chair the Public Health Council for the state of New York for the past 4 governors.
I didn't know that bit of vaccine trivia, but perhaps that will come up in a quiz at some point in the future. So what I wanted to explore first of all as a panel is, I guess the reasons behind why people are getting excited about interoperability. What are the opportunities that conceivably it could enable, not just as an organization, but for us as an entire health system? So Don, perhaps I could pick on you to start there. What do you think the opportunities are here?
Sure. I think that I think people are excited about interoperability because we've come, a good amount of way in the last 5-7 years. In particular, I think a lot of caregivers, when they see a patient, they're able to find out more about that patient. National networks like Commonwealth or Care Equality or Epic Care Everywhere have really kind of opened up a broader view of the patient. Hasn't solved kind of every nook and cranny of the patient data, but you have more than you did a decade ago. So I think that's underway, and I think there's just a couple great opportunities going forward. The two I would highlight are one is real-time interoperability. So finding out about events as they happen or lack of events, a gap in care, a patient didn't fill their medicine, one of your patients went into the ED over the weekend, just having that kind of awareness of what's happening with your patient in real time, I think is a real opportunity to take better care of a population and close gaps in care and that kind of thing. And I also think another opportunity is really kind of public health, population management, syndromic surveillance, identifying hotspots, those kinds of things for, public health purposes, like we've all been through over the last year and a half. Having a broader, availability of information would have been really helpful in fighting this pandemic for sure.
Yeah, Don, I agree. I would say the last year, interoperability hasn't been more important, at least to us. We saw the reasons very openly when, we had patients that tested positive for COVID in March of last year. And the only way to run that data or get that data was on paper from our state entity. And we did not have a way to interoperably, I guess is the word, share that to where it's a usable format for our physicians and clinicians on the front line. And I think for me, that's making me more passionate about it. And like, how can we get, we owe it to our patients, we owe it to our community to really be able to share information so that they get the best care when they show up at any facility, not just my facility or someone that's affiliated with me. Anywhere they go, they should be able, all the clinicians should really have that ability to see that data. So that's, to me, the biggest opportunity. It's, now is the time that we've got to talk about it more and really get organized, not just even in a state, but as a nation and as a world, to figure out how we can really, take away the barriers and share data.
And I'd add that those of us who, have been focused on health reform, one of the most challenging aspects of this was to really improve that communication and the flow of information. And an electronic medical record was the first step in a long process. And I would suggest that the promise of it's still pretty nascent. I mean, we're, as Don and Amy mentioned, it's helped us. We haven't completely hardwired it into our clinical model, but it's going to be a foundational element, I think, of innovation in the future. And it's not only from an internal perspective or our business model and strategic objectives and improving the quality of care. I think from public policy and from government's perspective, this actually will be helping us to better inform and understand exactly what's happening, issues of health equity, that we would never be able to achieve if we did not have that visualization of a patient journey.
Yeah, I agree with all the prior points. I think that interoperable health data will really allow us to move away from the prevalence of fee-for-service reimbursement models towards value-based care. A lot of the hesitance from providers, at least based upon my reading, could be easily addressed through technology. So one of the powerful things with a standardized interface is that we can really begin to have an economy of scale from the application developers and the technology space, so that we are not having to create standard or individualized integrations at each point of care. And we can really polish the implementations and have more quality and a more standardized approach, not only for the patient, but also for the provider and how they exchange that data. So allowing that data to really be summoned at the point of care would be a really powerful starting point, right? Where if you show up at a care setting in today's world, you're really providing all that information as if you've never seen a doctor before. So through interoperability, if you could, press a few buttons, we're not there yet, but eventually, if you can, in an easy way, have the data be shared, then that's going to be extremely powerful. It's going to just improve both the patient and the provider experience, very greatly.
Mm-hmm. It seems like, sorry, carry on.
I was just going to add, like what Josh was said, which is the standard is so important. Sharing data and it goes into a media file dump is not helpful to a doctor, a nurse, a dietitian, any of those folks. It has to be in a standardized format so that it's apples to apples and you know what you're looking for where. And I feel like that's a big, for the industry, that's a really important piece that we don't talk about a whole lot is, yeah, okay, great, I can share a PDF over or I can take one from someone else. But if that's not in a usable format for our clinicians, it's not really that helpful. So we've got to really focus on what are those standards, creating the standards and sticking to the standards, not customization when it comes to that data set, sticking to the standard and saying, hey, we're going to send you this information in this format. We're going to accept it in that format. We're not going to go and make new values for social determinants of health, or we're not going to go and change the depression screen that's already standard. We're going to give it to you in that format so that we can use that data moving forward. Otherwise, we're just sharing a bunch of text that nobody's going to look at.
Yeah, absolutely. That seems to be a crucial foundation for the conversation. Standardization is easy to say and put on paper, but I imagine it's a lot more difficult to to execute. So I mean, Jeff, maybe I could point to you for this one. What different kind of stakeholders need to be involved in that conversation if we're to approach some kind of system of standardization upon which the rest of this kind of interoperability opportunity could be built?
It's the age-old problem of data governance. I mean, even within my own organization, the nomenclature of how I identified a provider or their location or the services, So look, you need these recognized bodies that establish standards, and we also have to get rid of the tribal issues on health quality. Everybody comes up with a different ranking, and this, it would be great. And in New York State, we've been advocating, let's standardize all of the quality measures that go into what Josh referred to as the value-based contracting. Now, the stakeholders, this is not an IT problem, really. It is a policy. It requires the payers and providers of healthcare plus government, being frankly the largest payer in the United States. And you see CMS, I think, taking the lead in a lot of, through the Cures Act, going back to high tech and the Office of the National Coordinator, basically starting that conversation and shaping it. So I think the leadership, at least that's been shown, I think it's very dangerous, as Amy pointed out, when you get these one-off models because the states have a different, this really needs to be a uniform set of federal rules that essentially apply throughout, much like I think, although I'm not completely familiar, how the European Union kind of even created, the standardized nomenclature that's resonant in a lot of the medical records. So I think, there's obviously, we all have a lot of, stakeholders that are going to be advocating. You have a big risk is large companies that have invested in their products that want to keep them proprietary and use proprietary algorithms. That's just generally problematic, and it's antithetical to the public policy objectives that we're trying to do.
Yeah, to your point, or you want to go ahead?
No, go ahead, Jeff.
So to Jeff's point, what we see now is these conferences, connect-a-thons, these large events where, since we're talking about a standard, we're talking about commonly used technologies, we really can have all the various different stakeholders collaborate in the open because these are standards. So nothing is hidden, and the only thing that we are interoperating on are the things that are standardized, or else you have no idea how to interface with elements that are kind of developed behind closed doors or in secret. So I think we'll continue to move away from these proprietary workflows into more of a standardized model. And these large entities, like Jeff had mentioned, like CMS, will really have a lot of pull there, right? Where just through their scale and their enforcement and development in the ONC for the technical standards, through the enforcement of these standards, really gives everyone a platform to discuss these issues in a meaningful way. We're even beginning to see patient involvement, which is really exciting. We have a patient empowerment work group that's been recently formed, and they're very energetic and excited to contribute towards their own healthcare. So yeah, just really exciting. We couldn't have any of that occur without standardization. So it's just very important.
Yeah, and I'm sorry. Go ahead, Don.
No, I was going to say I'm feeling good about what CMS is doing around pushing these standards. I think it's a good role for CMS and regulation. I thought I'd never say a sentence like that, but nevertheless, it's a good interoperability standards. It's a really natural role to have a federal government agency kind of requiring it, pushing it. I really think it's gotten off the ground, the adoption of kind of a new wave of standards with FHIR, which I could explain if you'd like. But I just think that works really well. And some of the work groups like Da Vinci, identifying use cases between providers and payers and just kind of buttoning it down at a national level really helps everybody kind of know how to coordinate. Vendors know, what the doors to open up. People know how to how to work with each other around defined use cases. And that really helps all of us, I think, in this journey.
I would also add, there's a paradox here because I'm not a big regulatory approach on a lot of things, but the paradox here is the regulation. We can't view it as it's a compliance box and you're just checking it off. It's the regulatory framework that permits innovation, I think, here by standardizing it. So we'll see, with APIs, we're going to see a lot of great ideas on how to use the data, how to empower individuals, and how to produce insights that would otherwise be difficult to achieve.
Mm-hmm. So
yeah. Go ahead. I'm sorry, Jamie.
Regulation enabling the innovation as opposed to
I think so. Although I'm not a big regulator guy personally, but because sometimes regulation gets into micromanagement, and there's a difference here between managing the behavior as opposed to creating the environment for the clinical model to improve, I think.
I think there's with the 21st Century Cures Act in particular, I have a lot of feelings. I feel like the patient is deserving of their data as soon as I get it, right? So I'm the clinician, I get the data, you get the data. That's us working together, the patient really being part of that care team and really helping, hey, did I miss something? Let me know, bring it to my attention. I think where it gets a little more dicey for me is around the APIs and the third parties. And, I really feel very, very passionately that my role in this organization, as well as some of my coworkers, that we are really the data steward, right? We are the patient's data steward. We are there to protect that patient data, to make sure that it's not going to places that they don't realize. And I have a lot of concerns with what is the vetting process for the people that are part of this API for the second piece of Cures Act. I mean, how do we know are we checking to make sure, the patient understands that they're requesting this data via third party, or are we vetting that they are not selling the patient data or moving forward or using it in a way that the patient isn't understanding? And is that just done via a consent when you download an app, or is it really a process to me that might need a little bit more micromanagement to make sure that we are all collectively being that data steward for the patient's data?
So what I had found is that there is guidance from CMS that where you can only block somebody from connecting their third-party app to your APIs if they present a security threat to your system. So largely, they gave the example at a conference of the Nigerian Prince app. And you had a desperate cancer patient who tried every app on the market. So they download the Nigerian Prince app, and you're like, hey, this app is clearly bad. They're going to steal your data. But if the patient wants to do that and you give them the educational materials they need to give informed consent, it's their data. I entirely agree that this is new, and in a lot of ways it's very scary. But at the same time, I hope, at least maybe that's me being young and naive, that I hope that this will become, that'll become more of the edge case and not the norm. And that we'll see, it takes a lot of work to develop these apps. And then if you're on an app store, they'll take your app down if you're a bad app. So I don't see a lot of incentive to really do anything with that data as of now, just given that the development costs of creating an app, and then how is anybody going to find your app if you can't get on any of the large app stores because you're a bad actor? But yeah, that's a very common fear, but they took a pretty hard stance on blocking these apps from connecting to the APIs as well.
Right. And then what is that data that I'm sharing? So if you're a fitness app and you grant consent to me, I, Amy Trainer, say Ashner Health, you can, third-party system for my new fitness tracker, get my information from Ashner Health. What are the data points that I'm sharing? And then am I aware that maybe you have more than you need? And that's kind of what the take we're looking at is we don't want to block, but we're only going to give you the minimum possible because we don't feel like it's in the patient's best interest to share the whole kit and caboodle, right? Just because they possibly read something that they downloaded that was now asking for information from us. That's my big worry is people just don't know. And we've got to figure out and make sure that those apps are safe, yes, from a security perspective, but also that the patient understands what they're consenting to and what is our role in that, because they could probably do it on their device or whatever they're downloading the app on, but do we need to go and add another consent or do that double check to make sure that they really do understand what that looks like? And we're just kind of in the beginning of developing processes for that.
It's a really interesting one. I imagine over the years I've probably ticked the box and signed things having seen 2 pages of prose, and that's not really informed consent, right? I've scanned that and I've ticked that box, and so I guess it's around putting in the safety measures with the patient's best interest at heart. But part of that inevitably will be, as per GDPR in Europe, you are not only responsible for your stewardship of the data, but for that of third parties and third parties. So it's really a network thing, and you have to be responsible for the lowest common denominator ultimately. And so what different processes could organizations put in place to look to ensure the stewardship, not just in their own organization, but across the network that their data is shared with as well? That's an open question for the panel.
Well, I'll just to quickly adopt the other side of that, because that's sort of everyone's gut instinct is how do we protect this data? But if you think of this from the innovator's perspective, they need to connect with thousands of different health systems. There's 10,000 different health system endpoints in the US alone. There's over 300 health insurance payers. So if I'm an application developer and I want to make an amazing app, it's not going to be valuable unless that app could potentially be in any person's pocket. So if the burden of having to prove myself and jump over hurdles for 10,300 different health systems and payers, that could be really extreme. So we do want to protect the patient's data and do this in a responsible way, but also because this is a standardized interface, the standardized approach, you don't have a lot of freedom and flexibility to raise barriers that others aren't going to be raising. So so it makes it tricky there, right? We want to enable interoperability, but also we don't want it to become a dangerous thing. We don't want to become like the Terminator, like the countdown till the AI goes live. But I share all those concerns. But talking with these application developers, it's hearing their stories. They like a consistent way to connect.
Yeah, I do think the thread that Josh is on and Jeff also mentioned this, is that standards do create a level of innovation that can occur. For every developer to have to figure out how to hook up to all these different backend systems and get data out. The fact that regulations sort of require backend systems open up and that there's a standard by which you can kind of understand the information that comes out of these systems enables a lot of good apps, let's say, that'll help a patient better take care of themselves or be engaged in their care, or a physician have a better experience using the patient's data. So I do think that there's certainly a positive way to look at it. Back to Amy's point, though, I think this is the greatest kind of risk in this area, is really to have a level of control, visibility, understanding of the data sharing that's going on. And, I would think a key additional piece, in addition to just good education as the patient, specifies their initial preferences or their initial authorization on an app, is ongoing transparency. Here's the data that was shared. It was shared last week with so-and-so, or your data just went out to this pharma company in a de-identified way for this particular study, or those kinds of transparency and awareness beyond the original event, I think would be a nice, I know it's complicated, but kind of a nice addition to the picture, so patients really get a much better understanding of what's happening with their data, because they really do have a right to know.
Yeah, so here you're going to go, and this is one of the pendulum swings, okay? If you were speaking to 4 compliance officers from our respective organizations, you'd have a completely different discussion on this particular topic. So I've spent a lifetime liberating data, liberating it for my own organization and now liberating it on behalf of patients. And, you know, the bad players, the amount of times my organization's network is attempted to be penetrated, some of the successful ones, you know, we're very nervous. And I think we're going to move in a very cautious way. That 10,000 systems that Josh basically, or touch points that Josh described, is really going to be challenging. And you have 10,000 developers that are going to look to monetize this data for the benefit of patients. So, you know, it's beyond getting that good housekeeping seal of approval on the apps we're connecting. You need a third party that's going to minimize our legal exposure if we inadvertently think that, you know, the patient asks us to do it, we give it to a, you know, it becomes, you know, we're in the middle of the transaction. There's going to be litigation for anybody that's in that transaction of that data stream. But Don's point is, you know, who has the affirmative responsibility to make sure and inform somebody every time? It's like your credit report. You know, if you signed up for the credit report, you get a text when somebody does a soft inquiry or a hard inquiry. We're going to have to routinize that, and that in itself is probably going to be a business that we're all going to subscribe to, right? I need somebody that's going to manage that, because I'm trying to take care of patients, and I'll, you know, but that'll spawn yet another industry, I suspect.
I think that the key phrase there, Jeff, at least for me, was liberating data on behalf of patients, and it's that balancing act that we have to strike. You know, to what extent can we do that which is fair and reasonable and has informed consent, but also enables us to share data in a way which can provide better solutions ultimately. But one of the challenges I would imagine that there are lots of organizations and companies which have, you know, built business models and monetizing patient data which is owned within their moat to an extent. And so how do we overcome that competitive hurdle?
Well, you know, before I get to the competitive hurdle, let me just point out this. I think we're gonna, the fear I have, and I've had firsthand experience from some of the experiences we've done, is we're overwhelming individuals with data. And to what end? All right. And so, you know, everybody has a right to it. So it's absolute. It's not my data. I'm holding it on your behalf. I'm making it available where you direct it. And we, you know, then, you know, well, a payer is saying to us, I have the right, if as a function of insurance, if I'm going to provide you, I want contemporaneous access to your data. So you're going to have that discussion, or I will incent you, if I have contemporaneous access to your data, get a 10% discount on your insurance. You know, there is going to be a lot of these consequences of making this more viscous, or you know, that allows it to flow, because we're removing that friction and the barriers here. So I think that in and of itself is going to be a major issue. And then we're going to have to deal with the downside of, by transporting your data, you know, at some level you're with Oxner, you're with Northwell, you're with New York Presbyterian, you kind of stay within the system of care. The fear here is also you will end up fragmenting your care more by taking it and sending it to multiple providers. Because it's easy, second opinion, and nobody's quarterbacking the data, and it becomes less relationship based, more transactional, and that is also another possible outcome. I'm not saying it's negative or positive, but it's something we're going to be challenged to do.
So I think there's two different aspects of this. There's the a API sending data to an app for a consumer. And then there's an API sending data to another HIPAA covered entity so that they can operationalize that data. So there's going to be drastically different approaches taken depending on these two different circumstances. And the liability, at least from my understanding as a non-lawyer, is much greater for an exchange between one API to a HIPAA covered entity that they go and in turn use that data to provision care. So I think that we can find that you'll be a little bit more lenient for the data that's going to a personal device so that a consumer can just look at that data and use that data however they wish. But at the point that you're going to ingest data as a HIPAA-covered entity to provision care, that's when you'll want to be a lot more strict and stringent and have agreements in place with the entity that is sending data. You'll want to understand how they identity proofs that person, to how they, what processes they have in place, what's the security of their system. But you won't necessarily need to have all of those things in place for just sending data to like Apple Health or something like that.
And the other downside here is, you're going to have a segment of our society that is going, that is going to take exception to what some people would suggest are paternalistic comments. I'm here to protect you, so trust me. We're going to have to deal with, the whole issues of privacy. We're seeing it now with vaccine and vaccine passports, about the pros and cons of doing that. And it's, and the whole COVID experience underscored the importance of interoperability and early warning systems that still I'm having trouble in the state getting the data. But we'll get into public health maybe later.
Mm-hmm. But you're right. It seems like at the moment, as a result of COVID, it has underscored the need for interoperability, among other things, and it's provided an environment that has enabled greater innovation and speed. But as theoretically return to a sense of new normal, is there a risk that that environment snaps back and we return to a status quo and don't leverage the silver lining of the pandemic and what is enabled from an innovation perspective?
I mean, I hope not. I would say that this is our time. I feel like that's something I've been saying for the last 6 months, at least our state health entities. We don't have a better time to really come together and fix it as of now. To me, it is very sad that when your only official proof of vaccination is a paper card that is now being sold out there. We shouldn't be there. We are smarter and better and more advanced than that. But we have all of these barriers that we're not really taking down fast enough to kind of move that forward. No one should have a problem with your vaccination data is already, your other vaccination data is shared with your state already. Is the state sending it to the federal government? Sometimes, maybe not. Who are they sending it to? These are questions that I feel like if the people that work together like we are here today, who live this every single day, could talk on a more regular basis and really explain, like, guys, like, this is not a technical limitation. It's really that we're just not organized, and we need to be more organized, move things up different levels. I don't want to build interfaces to every agency in the state, in the country, in the world. That is a pain for me. I want to send it to a person that I know is trusted, and then they share it with the folks that are above them. And that is not happening, not consistently. It was like a Band-Aid that was pulled off during COVID. It is still that way for vaccinations. We've got to do something. I am very excited to hear more people talking about interoperability around, I know originally we were talking about claims data. Of course, we can talk about claims data, but like when you're talking about the thing we need now is really around, public health. How do we help? How do we use public health as the thing to move us forward and get us to that next level? And then the other pieces kind of fall into place. But this one, we've got a lot of motivation behind it. We just need to capitalize on it.
Yeah, unfortunately, we do have an ability to forget things quickly and snap back. But I'm optimistic. COVID was just such a, and still is, kind of a hard worldwide battle. And there was just such an obvious kind of connection to how public health could have been better with a connected, interoperable health system that I think we'll remember this and drive improvements so we can have kind of a next generation public health approach. It just makes so much sense. Pulling out the old ways of doing things, calling all the hospitals in New York every day. How many patients do you have there? And how many are in your ICU? How many have COVID? And hanging up the phone, writing it down, calling the next hospital. It's just, it was embarrassing display of lack of interoperability. And hopefully we can, get through this and rewire our health system.
Yeah, and Jamie, I would just say that this morning, right before this, I was on a call with the staff of the Energy and Commerce Committee in the House, and I have to tell you that there is no way this is not top of mind, and they are going to be. They recognize how it exposed the inherent weakness of our public health infrastructure. And they recognized that data and information was at the heart of one of the major fault lines. And they're absolutely determined to do something about that. And so I don't think we're going to go back. And I think for those of us in the business of liberating that data, be it in all claims database, this is our time to advocate for what will good data presented in a neutral way will drive good policy. And that's what I think our time has come, is to liberate that information for all the good reasons we discussed.
Yeah, so to one point that Amy made and everyone else sort of alluded to is how do we trust who we're connecting to, right? If you're talking with others, you don't want to make those 10,000 different integrations. So there are some good works that are occurring now in terms of trust frameworks, where there would be a trusted entity that would have a repository of trusted applications and trusted endpoints, so that you know that if I call out to this trust framework, I'll get back information that I can rely upon and operationalize to provision care. So in terms of like a vaccine certification, there's many different entities who could credential that you had received the vaccine. Perhaps you might look at your claims data and say, oh, well, you had 2 claims for vaccine administration, therefore you're vaccinated. Now there's several other entities to do that as well. Every state has their own immune information system. They all do not talk in the same exact way. So we'll have to have a standardized way and a way for everyone to go and call out and trust, so that we know that we're getting data in a way that we can understand and we can rely upon to sort of make those decisions. So I think that there's a lot of potential and a need for trust frameworks to occur, so that we can move beyond the, hey, here's my data on my iPhone, isn't that cool, but I can't really do anything with it, to the point to where we're actually operationalizing this data. So I have a lot of excitement in terms of the trust frameworks and how they're going to help this move forward in a very meaningful way.
So if we zoom out, maybe Don, I could go to you with this one. So if we to zoom out and look forward to a year or two, what would your hopes be for what interoperability would achieve and would enable within the broader healthcare system?
Well, I think, like I mentioned earlier, I think real-time interoperability, so a health system can take care of their patients, a payer can take care of their membership, I can identify gaps in care, can swoop in and help the patient at times of need, and really manage a population, whether it's value-based care scenarios, whether it's public health scenarios, treating patients as a group, and really managing and applying the resources where they're needed most. And I do think that we are kind of building that momentum. We're building standards. We're getting the technical infrastructure in place to really, take it to that next level. But I'd love to, get beyond the kind of pull scenario where you're pulling that record for that common view to more of the kind of manage and lead and take care of a population scenario. I think that would be very beneficial to get done in the next couple of years.
So kind of enabling that movement of healthcare to be more upstream, so keeping people out of hospital seems to be a kind of an underlying thread here.
Well, it's I think gaps in care is a good way to think about it. You're a high risk diabetic. You're supposed to be doing your A1Cs, your foot exams, those kinds of things. Are they happening? Are you picking up your meds? Are you having the right visits? Are things going off the rails where some level of care management or intervention or broader family awareness for for folks would be helpful to keeping the patient healthy.
Well, and also what you're really talking about is as we move upstream and downstream of the provider experience and go into addressing the social determinants, the ability to move this data on behalf of the patients is critical to a lot of organizations that don't have the infrastructure or the capability or the depth. A lot of these are not-for-profit social service organizations that are going to be challenged, that will benefit from the data, critical to their role, and we're going to have to figure out how to bring them and connect them, and who's going to pay for that and who's going to support that, because it's going to be critical. That'll probably be the subject of a lot of innovation at state level, particularly on the Medicaid programs, and you'll see some CMMI activities there. But remember, we're talking, if you come back to how we're going to save money, so we've got a $3.8 trillion spend in the country, but that's only on about 80% of that cost is on 20% of the people. And we got 50% of the population that we spend 3 cents of that dollar on. So, the promise of interoperability are on those most complex, chronically ill, multiple interactions. And we don't have to boil the whole ocean to solve for this. And it is going to need some focusing here because, and unfortunately, it might be that 50% that we spend the 3 cents on that are really into their health and stay healthy, that want to use all this activity. We got to figure out it's that other 20%, how to get them engaged to use all these tools and their providers and networks.
So Jeff, you kind of touched on the thing that I'm most passionate about. Now, Jamie mentioned a 1-year time frame. This will probably take much longer, but to really have a patient-centered set of data. So I've heard estimates that even if you took all the clinical and claims data, but if you were to supplement that with wellness data, so how much are you sleeping, what's your nutrition like, what exercise routines are you following, what's your heart rate throughout the day. So if you were really to have patient-owned wellness data, in addition to all of the patient owning all of their care data, and have that data be able to flow around with that patient to the point of care, wherever they may be. So if they go to a state-based clinic that has no resources, like you mentioned, could that patient direct that data, or could the provider, because let's just admit it, that not all patients are going to engage with this data or have access to electronic devices. So it has to be something that can be administered even without a lot of engagement from the patient. But having that data available and centered on the patient, I think it will be very powerful for building up a health equity, right? Where my activities today are really building out a trust fund of wellness for the future, and for me to kind of feel better and healthier and have less interactions with the healthcare system in the future. So more of a long game, but I think it's going to be very powerful.
Oh, I mean, Josh, if you kind of blue sky what's possible, think about social determinant. What you eat is so critical. Now, how can I go shop at ShopRite, same supermarket I use. I get everything has scanned. What if I could take the data from my weekly shopping in my grocery store and have that uploaded as well? And you could analyze the fat content, my calories, the sugar consumption. I mean, you could start thinking about how we connect those pieces of our lives to address the issue here. That's another company we could start up. That's another business. But, now we're going to have to compel ShopRite to give that to third parties. We're going to be in a little tricky place.
Yeah, we'll put a hand in the fridge that'll slap you.
Yeah, right. Every time you take something out, it scans it. You know what you're eating. I don't know. It's possible.
It's definitely possible. They might do it already. Who knows?
Yes.
What's exciting, I suppose, is that you can ask those questions and you can realistically shoot for the moon, which is fantastic. Couple of minutes to go, guys, and this has been a fantastic panel. So thank you. I feel like we could keep talking all day, but we want to be respectful of everyone's time. But I'd love to just ask you. You're all evangelists for this, and I think a big part of this is the advocacy of interoperability. So I'd love for your kind of final thoughts, key takeaways, or key messages for the audience, but before we wrap up, if that's okay. I'll start with you, Don, and perhaps make.
Yeah, sure. I guess key message wise, I'm quite optimistic about interoperability. I think we've done a lot, in terms of the last 5 years with standards, with regulation, with technology opening up systems, those kinds of things. And I think that, the pandemic has really, identified some areas where we could really take it to the next level, from a population management, public health point of view, enabling innovation point of view. And I think we just need to kind of seize this moment where there's motivation, a good foundation, a good, cooperative working relationship across the industry to sort of move the ball down the field. And I'm quite optimistic we will.
Fantastic. And Josh?
Yeah, I would like everyone to think of this as more of an opportunity and less as a threat. I realize that it's scary. There's a lot of new things. We want to protect the patient, right? There's a lot of potential for harm here, but I think the potential for good is much greater. And if we think of these sort of blue sky ideas, we can get there. It's largely not a technology problem. The technology behind all this is pretty trivial, to be honest. It's more of it's a person problem. It's a status quo issue. It's a competing interest, and how do we monetize this type of issue? So if we can sort of reframe how we think of this, from checking that compliance box to how do we leverage this to create value, improve care outcomes, and to just be better people, right? Maybe payers can try and fix. Payers don't have a great reputation all the time. Let's just be honest about that. So I think there's a lot of opportunity for payers in particular to sort of don the white hat, as it were. But yeah, just reframe it from a threat to an opportunity. Be a little bit optimistic about it.
Fantastic. Thanks, Josh. And Amy, what are your, key takeaways?
Well, I agree with what these guys said. Keep moving it forward. We've got to really focus on this. Now's the time. I would say it's like a movement. I don't want it to stop. I think we've got to continue to be more transparent. Transparency in sharing is now. It's not something that's in the future. We've got to all get okay with it and understand it. Find those trusted partners, really part of those trusted networks, like Joshua said. Really focus on how can we really enable the patient to continue to be part of the care team. It is their data. It is their information. We've got to continue to push forward with ways that we can interact with them and share data with them that will help their health. And be able to make a healthy life for them moving forward.
Absolutely. And Jeff?
Yeah, so interoperability in and of itself is not the goal. It's rather the competency that I think we have to attain in order to get greater care coordination, enhanced engagement with patients, satisfaction, improved operational efficiency, and to achieve public health and strategic objectiveness. It is the foundational element that allows us to act as a healthcare system of care.
Yeah, fantastic. So fantastic final messages there. So time for thanks. Thanks to everyone in the audience for tuning in and being so engaged and dropping us lots of questions. Thanks to the team at InterSystems for sponsoring and partnering with us on this, and to Don, Josh, Amy, Jeff. Thanks to you for your time and insights today. It's been a privilege, and we'll see you again soon.
Very good. Thank you.